Yeah, good day everyone. My name is Nouri Victor. I am a neurology applicant and I'll be doing the Cheng's comprehensive review in clinical neurology. We've done questions 1 to 10 and right now we'll be doing questions 11 to 15. I got a feedback of recent and that feedback was the fact that I use a particular word called affectation and I use it frequently. It's a wrong word and to my listeners, please pardon me for using that word. I want to try as much as possible to delete it from my tongue. So let's begin. We have question 11. A 59-year-old woman presents with altered mental status. There is restricted diffusion on the MRI, which is shown in figure 2.3. Which of the following is the most likely diagnosis? Now, here's our MRI. The options include A. Bilateral anterior choroidal artery stroke. B. Stroke from occlusion of the recurrent artery of Hubner. C. Stroke from occlusion of the artery of Percheron. D. Stroke from occlusion of the pericallosal artery. And E. Superior sagittal sinus thrombosis. Now, if we take a look at this MRI basically shows us an infarct. Remember that an MRI infarct appears as hyperintensities in the DWI, the diffusion weighted MRI. And if you look at this MRI, you see some hyperintensities in here. This is the level of the thalamus. So there's bilateral thalamic infarct. Now, for you to have bilateral thalamic infarct, usually this is seen if there is an occlusion of the artery of Percheron. So we are going to talk deeply about this artery. Let's start from the top. We'll start with the posterior cerebral artery, where it all begins. The posterior cerebral artery is a major player in the brain's blood supply. It branches from the basilar artery and it swings back to feed critical parts of the thalamus, the midbrain, the occipital lobe, and the inferior temporal lobe. It is in fact divided into three segments, which includes P1, P2, and P3. And each of these segments give rise to different branches, supplying different structures, and that's where the magic, or should I say pathology, happens. We'll start with P1 segment. Let's call P1 the pre-communicating segment. Now the P1 segment stretches from the point where the basilar artery splits all the way to the origin of the posterior communicating artery. It is deep in the brain and it gives off what we call the posterior thalamo-perforating arteries, and this goes straight into the thalamus and the midbrain. Now this is where it gets interesting. Sometimes instead of having these many tiny branches, you may have one artery called the Artery of Percheron, and this supplies both sides of the paramedian thalamus and the rostral midbrain. If this artery gets occluded, patients can suddenly become confused, drowsy, or even unresponsive. And you might think that it's a metabolic issue or an encephalopathy, but it's actually a stroke. So, P1 strokes, think altered consciousness, vertical gait palsy, and memory impairment, all thanks to the thalamic and the midbrain infarction. Now we have P2 segment. The P2 segment occurs after the posterior communicating artery, so we call it the post communicating segment. This runs from the posterior communicating artery all the way around the midbrain through the cistern. The branches here are quite busy and they include things like the thalamo-geniculate arteries, which supplies the lateral thalamus and the geniculate bodies, and basically that's where your visual and your auditory release system falls into. Now we also have the peduncular branches that goes into the cerebral peduncles, so that's basically your motor pathways are at risk. And finally, you have the posterior choroidal artery, which supplies the choroidal plexus, the hippocampus, the pineal gland, and parts of the thalamus. If you have an issue with the P2, maybe you have a P2 infarction, the symptoms can actually vary, and you can have things like the hemisensory loss, motor deficits, and even memory problems if the hippocampus is affected. Now, lastly, we have the P3 segment. The P3 segment is the quadrigeminal segment, and this is basically the cortical side of the PCA. Now, this segment travels through the quadrigeminal system and gives off cortical branches to the occipital and the temporal lobes. Most notably, the calcarean artery actually comes from here and it supplies the primary visual cortex. So, if you have a P3 infarct, patients usually present with contralateral homonymous hemianopia. Now, other branches include things like the parieto-occipital and the posterior temporal artery, which handles the visual spatial processing and object recognition. Damage here might actually mean that the patient can see but may not be able to recognize object or faces, and we call that the visual agnosia. So the takeaway from this is that one, your P1 feeds the deep brain, think of the thalamus and the midbrain, and your P2 feeds the transitional zone, still deep, but now we are covering around the midbrain, and your P3 is all about the cortex, so mainly visual processing. That being said, let us zoom in on our true hidden gem of neuroanatomy, and that's the artery of Percheron, also known as the great mimicker. Now, if you're not watching closely, it can fool you into thinking that the patient has encephalitis, metabolic encephalopathy, or even a seizure disorder. The artery of Percheron is a rare anatomical variant where a single lateral trunk arises from one of the P1 segments of the posterior cerebral artery and then supplies both sides of the paramedian thalami and the rostral midbrain. Normally, each side of the thalamus is actually fed by its own perforating branches from each of the PCA, the posterior cerebral arteries. But in some people, about 4 to 12% of the population, there is just one artery that does the job of both sides, and hence we have the artery of the Percheron. So, what structures does the artery of Percheron actually feed? Well, one, it feeds the bilateral paramedian thalami, which are involved in alertness, memory, and emotional processing. It also feeds the rostral midbrain, including structures like the oculomotor nerve nucleus and the reticular formation. That means that if this single artery gets blocked, it can take out both thalami and often takes out part of the midbrain. The result is a clinical picture that can be dramatic and very confusing. So what's the clinical presentation? There's something we call the artery of Percheron stroke triad, and it's classic, but these three may not always be present. So one, you have altered mental status or coma, and this is because the thalamus actually controls arousal and alertness. Two, you have vertical gaze palsy, and this is due to midbrain involvement. Three, you have memory impairment, and this is due to bilateral thalamic damage. This is a chameleon, and some patients present with confusion, others may have behavioral changes, others may have transient loss of consciousness, which can be mistaken as seizures, and that's why it's most commonly misdiagnosed. Now the question is, why is it hard to catch? Now here's the kicker. Early imaging may be normal, CT are often unrevealing, and even MRIs can actually miss it, except you do thin cuts through the thalamus. So you may have to rely on your clinical suspicion. If a patient has sudden confusion, bilateral thalamic findings, or any kind of midbrain dysfunction, think of an issue with the artery of Percheron. We've agreed that our answer is the artery of Percheron. Yeah, so we've reached the 9 minutes mark. We will soon get to 10 minutes, and I don't want to exceed 10 minutes. That being said, we're going to be stopping here today. See you in the next episode. I don't want to make this a very boring talk, so I think it's best we just end it today. So thank you for listening. If you need to watch this more than once, you may do that. That may help to reinforce the learning.